Thank you, Nanuka, for the introduction. So, I'm audible, right? Okay, I hope so. All right. Good afternoon, all. So, continuing with the oxygen therapy, I will be starting today my session on the use of BiPAP as well as HFNC. So, BiPAP, it is a mnemonic for the name goes as bilevel positive airway pressure. It is a type of a non-invasive ventilation, delivers positive pressure ventilation, which improves oxygenation, eliminates the carbon dioxide, as well as reduces the work of breathing. So BiPAP, as it is a bi-level system, so it provides positive pressure during inspiratory phase, as well as in the expiratory phase. So inspiratory pressure, it is known as the IPAP, expiratory pressure support known as the EPAP. Usually the IPAP is more than the EPAP, and the difference is the delta P, that is the pressure support, IPAP minus EPAP. EPAP is similar to that of P. So IPAP, inspiratory pressure, positive airway pressure. Positive pressures are generated during inspiration that allows to take deeper breaths than would normally be taken. So it increases the tidal volume and as a result reduces the work of breathing. Whereas the EPAP, expiratory positive airway pressure, it is generated during expiration. So it is similar to P. So what does it do? It sprint opens the upper airway, maintain the necessary resting volume in the lungs at the end of expiration, that is FRC, and helps to avoid secretion buildup and as well as prevents collapse. So it helps in better oxygenation. So whenever there is an increase in PaCO2, it is advisable to increase the IPAP. And when there is a decrease in PaO2, so kindly increase the EPAP. So what are the indicators? Type 2 acute respiratory failure, acute exacerbation of COPD, cardiogenic pulmonary edema or congestive heart failure, weaning from conventional ventilation, after extubation, neuromuscular diseases like myasthenia or Guillain-Barré syndrome, and as well as obstructive sleep apnea or obesity hyperventilation syndrome. So the modes, it has 3 modes: spontaneous, CPAP or ST. So what is spontaneous mode? It supports the breath of the patient that he or her takes on self. What about CPAP? It is a continuous positive airway pressure. It supports the spontaneous respiration by providing one continuous pressure throughout the respiratory cycle. So here the IPAP is always equal to the EPAP. And what is ST or spontaneous timed mode? A combination of machine delivered breaths such as respiratory rate and spontaneous, that is patient triggered assisted breaths. It supports the spontaneous breath but will provide mandatory breaths if patient fails to breathe within the set period. So how do we initiate the BiPAP? So when we start the BiPAP machine, start the machine with FiO2 of 100%, then you titrate it down to the lowest FiO2 necessary to achieve the target, that is SpO2 of more than 90%. So in order to treat the hypoxemia, increase the EPAP. So for that, incrementation is to be done 1 to 2 centimeters of water. So the minimum value of, to initiate is 4 centimeters of water, and maximum level can be taken till 15. And to titrate IPAP for work of breathing, so increase again IPAP when you increase the EPAP, so that the IPAP always remains above the EPAP with a difference of 4 centimeters of water. And incrementation is again 1 to 2 centimeters of water. Minimum being 8 centimeters, maximum 20 centimeters. With every change, whatever we make in the machine, monitor the patient for minimum of 3 to 5 minutes for any clinical response and ABG. Only after that, you keep on increasing or decreasing. So these are the common initiating pressures used: IPAP of 8 and EPAP of 4. IPAP, then you again increase to 2 centimeters of water, IPAP of 10, EPAP of 5, and so on and so forth. Contraindications, absolute contraindication, non-compliant patient. Because the BiPAP mask has to be put tightly fitted on the patient's face. So if patient is not compliant or not willing to keep the mask on the face, it is very difficult to go ahead with BiPAP. And unconscious patients or patients who are not able to protect the airways, because this is a non-invasive. So patient has to have the trigger. Relative contraindication, facial burns or trauma, because the mask is going to be put on the face. So if there are any trauma or facial burns, it will be difficult for the patient to wear the mask on the face. Excessive secretions, difficult to suck it out or to clear out the secretions by the patients. Following esophageectomy, hemodynamic instability, upper gastrointestinal bleeding, pneumothorax, and claustrophobia. If patients are claustrophobic, even a minimum of closure on the face would be very difficult for him or her to continue with BiPAP. So managing airflow and pressure related complications, BiPAP is otherwise a very safe modality. But if there are nasal congestions or nasal or oral dryness, try to add on humidification, nasal salines, and also maintain the hygiene. If there is sinus or ear pain, lower inspiratory pressures are to be used. If there are too much of gastric insufflation, so avoid excessive inspiratory pressures. Pressure should not be more than 20. Eye irritation, check for the mask fitting, because if the mask is not fitted properly over the nasal breach, there may be leakage, and that may cause eye irritation. And failure to ventilate, then use the sufficient pressures. And when you should know that BiPAP is not going to help me and I should stop. If there is a decrease in the level of consciousness or gasping of air, failure to improve, or there is a decrease in mental status, even after 30 to 60 minutes of application of BiPAP, there is persistent tachypnea and tachycardia, and these all, as well as we should not have any delay in endotracheal intubation. If you think that you should intubate, go ahead. Now coming to the next topic, HFNO or NC, that is high flow nasal oxygenation or high flow nasal cannula. So as you can see in the monitor, this is a complete setup of HFNC. So what does it do? It is used to meet or exceed the patient's inspiratory flow rate demands. In the sense, when a normal patient breathes, the amount of air sucked in is not very high. It may be approximately minimum to 15, max 20. But in conditions of respiratory distress, patient may require oxygen to a level of 30 to 60 to even 100 liters per minute. So in that condition, we need a high flow machine. A low flow oxygen device will not help. So there is less entrainment of room air, reliably delivered FiO2 and maintain a constant FiO2. A FiO2 can vary from 21% to 100% by air oxygen blender. It improves the breathing pattern. Anatomical oxygen reserve is increased due to the carbon dioxide washout effect, as well as decreasing the rebreathing of carbon dioxide. It reduces the dead space and work of breathing. So there is a continuous delivery of high flow, which generates the peak. So 35 to 60 liters per minute flow will generate expiratory pressures of approximately 2 to 3 centimeters of water if the mouth is open, and 5 to 7 centimeters of water with the mouth closed. So when the PEEP is increased, the expiratory volumes also tend to increase. Improve air alveolar recruitment. So what are the physiological benefits of HFNC? So the anatomical dead space is reduced, work of breathing is reduced, gas delivered is humidified, it provides positive airway pressures, airway resistance is decreased, and FiO2 values are higher and are stable. So what does HFNC do? It mainly provides optimal humidity as well as a high flow. For optimal humidity, the mucociliary clearance is improved, or rather it is maintained. So once the mucociliary functions are maintained, the clearance of secretions is better. As a result, there is reduction in the risk of respiratory infection. Because it is humidified and heated, it causes comfort to the patient because the metabolic load is also decreased. Whereas high flow causes accurate oxygen delivery, washout of the anatomical dead space, and there are lower levels of PEEP. Indications: acute mild hypoxic respiratory failure, respiratory support post-extubation, pre-intubation oxygenation, post-cardiac surgery hypoxemia, weaning therapy from either CPAP or BiPAP, COPD, respiratory support to children with neuromuscular diseases, as well as apnea or prematurity. The contraindications, the absolute contraindications are if you have a known or a suspected skull-base fracture or there is a CSF leak, there is significant pneumothorax which has not been treated with chest tube, complete nasal obstruction, active epistaxis or recent FES surgery. The relative contraindications: hyperbaric respiratory failure, hemodynamic instability, facial abnormalities or injury, excessive oral or nasal secretions, bowel obstruction, agitation or poor GCS score. So this is the HFNC setting. It has a flow meter, an air oxygen blender, nasal cannula, heated inspiratory circuit, and an active humidifier. So going one by one, the flow meters are capable of flows up to 60 liters per minute. The air oxygen blender, it escalates the FiO2 from 21% to 100%, it's irrespective of the flow rates. The humidifier heats the gases at the temperature of 32 to 37 degrees centigrade and humidification of 100% with active humidifier. They have heated wide bore tubings. They deliver the gas from the gas supply to the nasal cannulas without condensation. So here the breathing gas passes through the center of the tube and warm water is circulated on the outside part. Then there is a patient interface, which is of different sizes and types. So there is a wide bore nasal cannula, which conveys the oxygen air blend from the gas tubes to the patient's nose. So these are the nasal interface. They come in various sizes, adult, junior. There's a tracheostomy interface, as well as there is a mask interface. Initiation of therapy, appropriate patient selection, very important. There should be no contraindication to HFNC, high likelihood that the patient will tolerate HFNC, and reasonable expectation that HFNC will be adequate to stabilize and or reverse the current respiratory status. It is not that we are using in those conditions where we know that intubation is required, but in order to delay the intubation, we are using HFNC. That is not a wise way to start a therapy. When we know that HFNC is going to help, then only we should initiate it. So we should attach the nasal prongs of appropriate size. What does appropriate size means? It should not fit the nares tightly. It should occupy 50% of the nares, and the distance between the prongs should be enough not to put pressure over the septum. Next, we start the flow at 30 liters per minute and then increment to 5 to 10 liters per minute to a maximum flow of 60 liters per minute. Once the FiO2 of desired air arterial oxygen saturation is met, we stop it. Now the humidified desired temperatures are also checked. So the gases are heated at 32 to 37 degrees centigrade and humidified at 100%. And after every 2 hours, we will try to reduce the FiO2 to stabilize it. So during the complete HFNC session, what are we supposed to do? We are supposed to monitor the patient. So what do we monitor? We see the comfort and the tolerance of the patient with HFNC. There is a continuous monitoring of the vitals, that are the heart rates, SpO2 and blood pressure. We check for any respiratory distress by checking the respiratory rate and the accessory muscles use. Frequent checking of the nares for any erosion or secretions, leading it to blockage. the sensorium of the patient, and ABG baseline and after every 1 to 2 hours, and chest X-ray wherever clinically indicated. However, taking ABG is an invasive method. We can also use this ROS index, which is a non-invasive parameter. It is a respiratory rate oxygenation index where the formula goes by saturation SpO2 by FiO2 divided by respiratory rate. So it predicts whether the HFNC is successful or failure. So if the ROS index is less than all these values at 2 hours, 6 hours, and 12 hours, we come to the conclusion that this is not helping and we should go to the next step of either NIV or we can go ahead with intubation. So in acute hypoxic respiratory failure, ROS index in the range of 4.2 to 5.4 measured at 6 to 12 hours after the HFNC initiation is a good predictor of successful weaning from HFNC. So the weaning criteria. Once the patient has a stable heart rate, respiratory rate, SpO2 and blood pressure records over the last 24 hours, and there is no evidence of increased work of breathing and the blood parameters are within normal limits, we go ahead with weaning. How do we do? So first we decrease the FiO2 by 5% every hour till it reaches 40%. Now, once FiO2 is stabilized at 40%, we taper the flow rates by 2 liters per minute every 2 hours till it reaches 20 liters per minute. Now, once this is achieved, we shift to a conventional low flow oxygen device where we can continue with less than 20 liters per minute at FiO2 of 40%. So how do we do the equipment maintenance? The nasal cannula, the heated breathing tubes and the chamber kit are not to be reused. It is one patient use. And in a patient also, like nasal cannula is to be renewed every 14 days for an adult and for 7 days children. For breathing tubes and the chamber kit, every 14 days. Air filters, every 100 hours or every 3 months, whichever is earlier. Unit cleaning, run the disinfection cycle after every patient. And unit keep-up, we should fully inspect and damp dusting. It should be done daily and before use. Complications, local nasal trauma, discomfort and pressure areas, pneumothorax, epistaxis, gastric distension. So it should be avoided by, can be avoided by keeping an NG tube. Blocked cannula due to, blocked nasal cannula due to secretions and delay intubation. So factors determine which system to use. When is NIV preferable and when is HFNC preferable? NIV is preferable when there is increased work of breathing, there is hypercapnia, and it is efficient and economical use of oxygen. Whereas HFNC is preferable when the need of high FiO2 is required, that is in hypoxia or hypoxemia. Need for humidification and comfort and acceptance is more for the patient. So HFNC provides high FiO2 to patients with acute hypoxemic respiratory failure with PF ratio of less than equal to of the range of 150 to 100. But meta-analysis have shown to demonstrate there is a fail to decrease in the rate of intubation or mortality with HFNC. Again, there are trials in ARDS which have shown decrease in the work of breathing, decrease in the respiratory rate, and increase in patient comfort with HFNC use. And in Florali trial, where patients with acute hypoxemic respiratory failure and without hypercapnia are treated either with HFNC or standard face mask, oxygen, or NIV, did not result in significant different intubation rates. However, there was an improvement in the 90-day mortality, especially in the HFNC group. Pre-intubation oxygenation, HFNC can be used both during and as well as before and during the endotracheal intubation. Post-extubation, it helps as well as prevents as well as treats the post-operative respiratory failure. In COPD, it does not reduce the frequency of COPD exacerbations, but it decreases the duration. In conclusion, HFNC is an alternative to other high flow systems and NIV. The choice between these systems depends on patient and clinical preferences, need to ventilation and PEEP, severity of hypoxia, and institutional availability. So we should know when to use which. So here goes the, not a flow chart, but you can say initiation of the therapy. Start with the low flow oxygen therapy. If not maintained, go to high flows. Change to NIV and then to invasive ventilation when required. Thank you.
Continue first with the
No, I'll go with the demonstration now.
Okay. First we will do the demonstration. Okay. First we will do with the demonstrations. Then we will do the discussions.
Can I see my video also now?
Yes.
I can see now because no, first let it be there. I'll just let it be there. Because I'll just show the parts before. Huh?
By the time you can write your queries here, okay? First, we will demonstrate this thing HFNC here. Then we will take up your questions and we will do the discussions. Okay? You want to sit here?
No. I will be doing with this. Yeah? Okay. I guess I'm done, right? Yeah. So, BiPAP mask. Okay, this is not the authentic BiPAP mask, but this is how a BiPAP mask looks like. It has a mask that is to be tightly fitted on the face. Okay, and this is the forehead harness. This is the head strap or the gear. So I'll put it on myself, I guess. Okay. So this has to be in the nasal bridge and this towards the chin. And I can't talk if I put it. Okay, anyways.
You want to put me?
I'll put on you. Okay, fine. So I get a volunteer. You have to open your specs. Okay. It's okay. So the mask is fitted on the properly over the face, and this is the headrest. Okay. There is a headgear which has to be fixed properly over the. And you can tighten it as required. Okay, so sorry. So it should be completely sealed so that there is no escape of any air. And this will be connected to the oxygen supply. Yeah. So this is how a BiPAP mask is put on the patient. Now come to the HFNC setup. Yes, sir. Some more the same. Yeah. Down. Down. One. Okay. So when we start with the HFNC machine, we should know when this red tubing is poured, that means that this has been sterilized, disinfected and sterilized properly and kept. This is ready to use. Sometimes it is also sealed in a plastic pack, but this itself also shows that this is ready to use. So first thing, we will disconnect this red tubing. So we go ahead with the parts. This is the humidifier. This is, can you see? Can you see this steel plate? Okay, fine. This plate is the heating device that will heat the gases. This tubing will be connected to the sterile water for circulation, and at the back there is a port that will be attached to the oxygen source. So I will just fit and there is a connector that has to be connected over the humidifier. So once these connectors are put over the humidifier, now we have to push this level down and slide it over. Can it be seen? Simple. Bring near, down. Okay, fine. Just push it down and slide this. And you'll hear a click. Okay, once you hear the click, that means this is attached properly. Now, this water tubing will be connected to the sterile water source. Okay. Now, once this is done, we will attach the tubing. For attaching the tubing, you will see that there is this blue cover. You have to pull it back, and then align accordingly. Come here. That's it. You have to align accordingly. This will be put towards this. Once it is done, push back the blue cap. This is already connected to the interface. This is a nasal cannula interface. Okay. So you can see this is not like the normal nasal prongs. It has a wider bore and has wings. So as it connects properly, and then it is harnessed on the head with these straps. So once this is done, the oxygen source is attached to the cylinder, and mainly this is just for demo. Usually it is attached to the wall mount or pipeline system. So after this is done, we will switch on the machine. On this side. So this is, we are demonstrating the Airvo 2 machine. No. Exactly. That's fine. So we can see that there is a bird and a butterfly. So this is in the pediatric mode set. So if we need to change it to the adult set, we have to press the play button for around 10 seconds. So the pediatric mode is stopped, and we have come with the new setup. This is the adult setup. Okay. So in order to change the temperature, the flow rate, and the FiO2, we have to press this up and down button together. If you press it for some time, yeah, sorry. So with the play button, you come to one of the parameters. So this is the temperature, but it is in the locked form. In order to unlock it, you have to press the up and down together. Yeah. So now this is unlocked. So you need to increase or suppose decrease. Suppose it was 37, I brought it down to 34. So again, in order to set this, you have to press the up and the down arrow together. It's play button. Okay. So this is done with the temperature. Now next is the flow rate. We need to increase the flow rate. Unlock it. Either increase or decrease. So I'm increasing to suppose 25 liters per minute. Play button. It's locked. To the next temperature. This is FiO2. If I need to change this, we need to do the same thing again, press the up and the lower button and increase the FiO2. So now we have the setting of 31 degrees centigrade with 25 liters per minute and saturation of 21% oxygen. So once this is done, we start off the monitor. And what is the physics behind this? The oxygen will enter. Show the behind here. Yeah, okay. So oxygen will be entering from here, the one that we are supplying, as well as room air will be sucked in from these ports. Once it will be sucked in, this is the air oxygen blender. It will blend inside. And then it will be circulated within the humidifier. The air the water will keep on dripping. You can see the water, it will be keep on dripping, but it has to be below these arrow marks. So once the plate is being heated up and the water is getting heated up, so what happens when the oxygen and air is sucked in and along with the water vapors, it will be circulating. It enters from this port and it will move out from this port and move through the tubings and reach the patient through the interface. Is it okay? Okay. So that is how HFNC is connected to the patient and it works. So where you understand the situation is required for HFNC to be used, please go ahead with HFNC and treat the patient. Thank you.
We'll do the discussion
Yes.
here now.
Yes, we can do the discussion.
Thank you, Dr. Priyanka, for the wonderful sessions. Now we came to the end of our sessions. I just wanted to request you all, those who have any queries, you can raise your hand and you can ask your queries. I've seen one hand raised by Thailand. Can you unmute yourself and you can ask? I have not seen any questions in our chat box. Thank you. Some participants have given a feedback for these presentations. Thank you. And the demonstration is also clear. Thank you so much for your feedback here. Thank you. So if you have any queries, you please write down your queries here, or you can unmute yourself also. Thailand, can you unmute yourself and you can ask your queries here? Yes, post-test link and feedback link we have shared already here. I hope pretest has already completed. We have still 10 minutes left, so you can ask your queries. I think presentations was nice. Nobody have asked any questions. Yes, anyone wants to ask any queries? Yes, one question is asked by Vinita, like to what level we can increase the oxygen level in elbow 2?
60.
Vinita, you got your answer. Thank you for your feedback. Promila. Any other queries? You can raise your hand, you can ask your queries also. I've seen only one hand raised by Thailand. You can ask. Okay, thank you, ma'am, for the demonstration. Is very clear. Thank you. Thank you.
Thank you.
Okay, one is asked by. Okay, let me.
Where is that?
Wait. One question. Wait a minute. You can ask. I saw one question.
There is a question.
Yeah.
60 liters for both adults and just come down.
Down?
Come down.
Oh yeah. 60 is the same rate for pedia and adult.
No, it is not the same rate. You can keep on increasing as it is required. It is not necessary that all the patients will require 60 liters per minute. It is according, because you're initiating from 30 liters. Then you will keep on increasing till you attain the goal.
We are not giving any assignment and exercise.
Should the sterile water used through the tubing should
be changed every day?
No, once it is over, you can change it. Because it will be continuously working when the HFNC machine is working. So yes, one thing you should keep in mind, the chamber should never be absent of water, because once there is no water, there will be no humidification and the entire purpose of HFNC will be negated. So yes, there should be a continuous supply of water. Once the bag is over, you change it to a new bag.
Thank you. Hope you got your answer. Any other questions? Here we are not giving any assignment, no exercise. This is 9-day class. So we are giving certificate with the credit hours. That's it. Can we use NaCl solution instead of sterile water? Asked by Bidita. No. Here we are suggesting only to use a distilled water, because if you are using other than distilled water, then there is a chances you may damage.
Electrolytes will be, there may be sediments. So we are asking only distilled water.
Okay. Any other questions? Anyone wants to ask? You can unmute yourself. I think Manisha, they can unmute. We have given access to unmute them.
Yes.
Okay. You can ask your queries. Thank you. Post-test, we have given post-test link. We have already shared with you. Thank you, those who have already submitted post-test and pre-test. Okay. Zarina is asking one question. Wait. It's good. Ma'am, some hospitals are even using a tap water for humidifier. What is your say on this? Tap water.
Until and unless it is sterile way, you can use. Yes, it has to be water. Distilled water is preferable. Kindly stick to the protocols of using distilled water.
Actually, we are not suggesting for the tap water.
Tap water, we usually, I don't know.
Because
how are they using it? How are they putting it in the bag? I want to know that.
Yes, you can unmute yourself and can you share your experience?
Yeah, that's what I really want to know, but it is not advisable.
Yes.
There was another question, I guess. Yeah. Oh no, before that.
Yes.
There, up.
Why is there the need of heating the humidifier? If the humidifier is still on room temperature, do we need to heat it?
Heating the humidifier, what happens in the normal respiratory respiration? When we breathe in air or the room air that we breathe in, the anatomical area of our nasal cavity and the nasopharynx, what happens there? That is a normal physiology that is being taken care of. It is being humidified as well as heated. It comes to the body temperature. So the comfort level increases with humidification and heating the air that we are giving through HFNC.
And plus also what will happen when we are heating, this air will form the kind of droplet kind of thing.
It's the vapors. It's not the actual molecule. Madam, it's the water vapor molecule that is being carried in.
Yes.
That is the reason.
Yeah, and if it's a water vapor, then size of the water vapor is much bigger as compared to the viruses.
Exactly.
Especially during COVID time, we have used the humidifier in a large extent because the size of the virus is much smaller as compared to the vapor. So that's why the vapor will not carry the viruses inside. But if you are not heating, then there is a high chances that viruses will go inside.
Yes.
So that is the one main reasons to use humidifiers.
Yes. They are asking why is the heating necessary for humidification? Same.
Just to convert it into vapors. Okay. Thank you for those who have raised your queries, because maybe it will be helpful for those who are not able to ask your queries. Thank you. Okay, I have. Ma'am, what we have to sterilize all those tubing?
Tubing is one. For tubing, you have to
please unmute yourself. Those who are not talking, can you please unmute yourself?
Tubings has to be changed every 14 days.
Because that tubing is cost so much. If the people are a little bit, financially poor, and if they are not able to buy, then it's very expensive for them. This, I think, tubing is costing around 4,000 to 5,000, I guess. 4,000 to 5,000 that tubing is costing. So to change daily is not possible. So that's why at every 14 days, that is recommended timing to change the tubing. Any other queries? You can, if distilled water is, if distilled water is not available, can we use boiled water after school?
How are you going to do with the tubing? The set?
Yes, if you are using boiled water, then how you are putting in set and how you are connecting?
No, because it has to circulate inside the humidifier. How are you going to put it? Exactly. Even though if it is boiled and cooled. Mucormycosis.
Okay. Any other queries? Now I'm not able to see.
No, we cannot use.
Yes, peacefully have asked, can we use tap water?
No.
Hello, ma'am. Am I audible?
Yes, you are audible.
Yes, ma'am. Thank you so much for the presentation. Actually, when you were talking about the fitting of the mask tightly to the patient's face in such a way that the tip of the mask touches the forehead and the chin. Ma'am, if we want to avoid causing skin bruising, is there a way where we can apply a gauze piece before applying the tubing so that it can fit well, or?
There are silicone pads. This will not hamper, because even if you put a gauze piece, there are chances of leakage. And
Right.
if there is a leakage, so the whole purpose of using it as a tight fitted mask is not available, right? So that is not advisable. But yes, there are some skin protecting like bandage, not the normal bandage, but there are some kind of stick-ons that you can stick, and over that you can put the mask. But if otherwise you can just try to put it in between. You can just relax and let it let the skin breathe for some time, and again put it maybe for a minute or so.
Okay,
and
thank you, ma'am.
And you can give the skincare. That is the most
definitely.
Is,
you have to take
skincare is
care
the
of
most important. You can give that one,
because pressure sores can happen with the mask.
Yes, ma'am. Okay, thank you, ma'am.
Thank you for asking. Thank you. Any other queries? We have 2 minutes left. Thank you. Those who have submitted post-test feedback link, thank you so much.
I
think we can stop now. Yeah. If there is no more queries, then we will stop today's sessions and we will meet tomorrow. Is that okay? Thank you, Dr. Priyanka, for having wonderful sessions.
Thank you so much.
Thank you all the team for supporting for this training. Thank you, Dr. Sunny, also for these sessions. And we thank you all the participants. Be there during whole time and asking your queries and also completing both the tasks, pre-test, post-test. Thank you so much. We will see you tomorrow.
Questions they can ask.
Yes, if you have any other queries, you can ask in our WhatsApp group also. We will answer there also. Okay.
Okay.
Do you have any queries? No.
Ang girasan niya ito.
We'll wait for messages, I guess. Yeah, we will wait for your message. Yeah.
Daw. Yang mah mendadak kena ini. Mendadak orang adu arus.
Thank you. Thank you. Thank you. Thank you. Munishwar, we can end the session.
Okay, thank you. Thank you all.
Thank you, Munishwar. Thank you, everyone. Thank you.
Thank you, ma'am.